evening, everyone. We will wait for a few minutes for about participants to join. So, good evening to all. We just wait a few more. Uh, I think this is the second session of the webinar series. With the speaker is Dr. Vidya Krishnan. At the outset, I would like to thank. Can you hear me?
Yeah, we can.
Yes, sir. Yes, sir. You're audible.
Thank you. At the outset, I would like to thank IAP Kozhikode for associating with this, hosting this webinar series. We're not able to learn it the last day. It will be much more useful to a lot of people. I thank the IAP President for branch, IAP Kozhikode Secretary Vishnu is here. I thank him for helping me with this. Vishnu, you would like to say a few words?
Yes, sir. Respected seniors and my dear friends, very good evening. First of all, I would like to congratulate Dr. Satish and team for organizing such a wonderful webinar series. And the topic, very like the moment we released the flyers, there were a lot of people who were interested to join the webinar, and the recording was also very much sought after when the first webinar was over. So I take this opportunity to congratulate Dr. Satish and and a big thanks to our speaker, Dr. Vidya Krishna, for being with us for all these series of webinars. And I wish you all a very good day of learning. Thank you very much.
Thank you, Dr. Vishnu. I think without much ado, we've already introduced the speaker the last week. She is a consultant in infectious diseases in Apollo Hospitals, Chennai. Over to Dr. Vidya Krishna.
Good evening, all. So I'm going to start directly because I think we're already delayed quite a bit. Thank you for the kind introduction. So today we're going to be talking about management of resistant gram-negative infections. So this will be the agenda. We'll give a slight introduction, classification of gram-negative bacilli and the resistance mechanisms. We'll talk about what antibiotics are useful. We'll try and do a case-based approach, and finally we'll summarize. So when we typically try to classify your gram-negative bacilli, if you talk to a microbiologist, this is how they would do it. Like if your lab calls you saying that there's a gram-negative bacilli in the blood, especially if it started already growing on the McConkey agar, then you could ask them whether it is a lactose fermenter or a non-lactose fermenter. So typically when you talk about lactose fermenters, you think of three main bugs: E. coli, Klebsiella, and Enterobacter. Citrobacter and Serratia are late lactose fermenters. So sometimes they might get picked up as a non-fermenter. Whereas if you have a non-fermenters, there you have typically four bugs which are very important. So the first thing that you can ask them is that oxidase positive or negative. So if it's oxidase positive, then you know that you're dealing with either a Pseudomonas or a Burkholderia, most likely. Or if it's a non-lactose fermenter, but it's oxidase negative, then you're talking about Trichotillommonas and Acinetobacter. Obviously, we have a lot of molecular mechanisms and direct tests to identify gram-negative bacilli these days, but knowing the typical basics is still important. So the basic difference between a gram-negative and a gram-positive is just in the cell wall and the cell membrane. The gram-negative has a very thin peptidoglycan layer, which is the predominant part of your gram-positive cell wall. What really gives virulence to the gram-negative bugs is the cell wall. I mean, the cell membrane, the outer membrane, which makes it thick, resistant to antibiotics. It induces immune response as well as is responsible for the toxin effect. So if you want to choose the right antibiotic in an MDR gram-negative bug, you obviously need to go through your typical route of what is the patient host factor, what bug are you dealing with, what is the susceptibility pattern, what is the source of infection that you're looking at. But I think when you want to know whether a patient is really at risk for an MDR bug, then some questions you'll have to go through. How sick is this patient? What is his prior antibiotic exposure, especially in the last 90 days? Whether he's had any prior known colonization and any recent ICU stay or any recent procedure or surgery that he has undergone, immunosuppression, any form of immunosuppression. What is the local epidemiology, either in the community or if he's been in the hospital, then what is your local epidemiology? And is your unit dealing with any outbreak? So based on all these questions, then you can sort of reasonably predict whether your patient is at risk for an MDR gram-negative. Okay. So typically when we talk about gram-negative resistance, we classify them into two ways. One is your enzyme-mediated mechanism. Another one is your non-enzyme-mediated mechanism. So enzyme-mediated, all of us should know this. This is called the Ambler classification. So Ambler classification, you have A, B, C, and D. So class A is your ESBLs. ESBLs are your extended spectrum beta-lactamases. It also includes some carbapinamases. The ones which are labeled in pink are all the carbapinamases. So KPC and other carbapinamases are still there. Class B is your deadly bugs, your metallo-beta-lactamases, your NDM and all that. Class C is your AMP-C, easy to remember. And class D is your OXA. Any type of OXA enzyme is a class D mechanism. So these are one group of resistance mechanisms. The other ones which you can have are the non-enzyme mediated. So there can be two types. One is your porin mutation, which means that the antibiotic cannot even enter into the bacteria. or efflux pumps, which means that the bacteria actively pushes out the antibiotic. So whatever goes in keeps coming out. So these are various mechanisms. So when you're talking about an enzyme-mediated mechanism, it's sort of easy to say what drugs will work and what will not work. So if you look into the common ones, which is the ESBL, that is the extended spectrum beta-lactamase, you expect them to be resistant universally to third and fourth generation cephalosporins. Most of the times they are sensitive to beta-lactamase inhibitors. They are resistant to aztreonam, and they are 100% sensitive to carbapenems, which are the drug of choice. And the fluoroquinolones, Cotrim and all that are variably sensitive. So on average, if you look into Indian data, 70 to 80% of your isolates will be ESBLs. On the other hand, if you look into AMC, which is a class C type of enzyme, here again the BL-BLI is also gone. So you're only left with carbapenems. Okay, so this is about 40%. And carbapenem resistance means everything is gone. And aztreonam can be variable, which means that it will be sensitive only to your MBLs, metallo-beta-lactamase. It will not work on the other carbapenemases. So this again can be, even with the slightest estimate, around 5%. So we'll go on to a case so that we can understand these things better. So we have a 12-year-old boy weighing about 60 kg who is now admitted with a perforated appendicitis in a fluid refractory septic shock. So you want to score his multi-drug resistance screen. So you know that you ask him and you ask the family and there is no prior antibiotic exposure. So there is no recent hospitalization, nothing. So he's just come in from the community with a bad intra-abdominal sepsis in a fluid refractory shock. So now the surgery team is going to plan a source control. Blood cultures have been drawn. So now what antibiotics do you want to start? So do you want to go with ceftriaxone, amikacin, metronidazole, piptaz, amikacin, metronidazole, meropenem with or without amikacin and metronidazole, any of the above, but I will also add vancomycin. Okay, so now we need to know this is a community acquired, what looks like a gram-negative sepsis, isn't it? So this is an intra-abdominal source. So what is the rate of gram-negative resistance in the community? So if you all can follow this ICMR annual report. So this ICMR now releases an antimicrobial resistance report every year almost. So there's one from 2021 as well. So this is what they say for Enterobacteriaceae, which are the commonest bugs that you expect in your intra-abdominal infections. So cefotaxime resistance is close to 20 to 26 in the urinary and the non-urinary isolate. So which means that you cannot use that in a community-acquired sepsis, gram-negative sepsis, virtually out. The only bugs which seem to have good susceptibility are piptaz, carbapenems, and amikacin. Fluoroquinolones are also out. Okay, but which means that you are tied between piptaz or carbapenems even in a bad community-acquired gram-negative sepsis. Aminoglycosides generally we don't routinely add on because aminoglycosides are not drugs which have very good tissue penetration either into the lung or if you're thinking about a pus like abscess cavity, it doesn't penetrate well. And obviously you cannot rely on an aminoglycoside as a standalone. So if you're using something like ceftriaxone, amikacin, metronidazole, which means that in most situations amikacin is a standalone drug. So that combination cannot be used. And again, routinely, if you're in the habit of combining aminoglycosides, especially if you're already going to use a BL-BLI or a carbapenem, aminoglycosides are going to add very little to the efficacy, but they might add to the toxicity. So which means you will be left to choose between a BL-BLI and a carbapenem. What other drugs do you want to cover? Whatever bugs do you want to cover in an intra-abdominal infection? Obviously, you want to cover anaerobes if it's a bowel pathology. Remember that when you're using BL-BLI and carbapenem, they are sufficient enough. You don't have to add an extra anaerobic cover with a metronidazole or anything like that. Similarly, if it's an healthcare-associated infection, then if you're using either tigecycline, then you would already have an anaerobic cover. Whereas if you're using a colistin or ceftazidime avibactam, there is no anaerobic cover. So remember that you will have to add an extra anaerobic cover. So for gram positives, normally we would only cover aerobic strep when you're talking about a community-acquired sepsis. So if you're using a BL-BLIs and carbapenems, that itself should be enough. You don't have to add an extra vancomycin or a teicoplanin in a community-acquired intra-abdominal sepsis. Again, if it's a healthcare-associated infection, if you're using TG, that will cover as well. And when do you cover candida? We'll always have a separate talk on this, but generally recent abdominal surgery, an anastomotic leak, a bad necrotizing pancreatitis, a patient who is on broad spectrum antibiotic but is not improving, or if it's an immunosuppressed host. So these are the broad ways to approach an intra-abdominal infection. So now coming back to the crux of the story. So what do we want to use? Whether we want to use the beta-lactamase inhibitor or a carbapenem in a bad community-acquired sepsis, gram-negative sepsis. So they actually tried to do a randomized control trial called as a very famous Merino trial. So among patients with ESBL E. coli and Klebsiella pneumonia bacteremia, they started with the question, is piperacillin-tazobactam non-inferior to meropenem? And then they ended up with the answer that piperacillin-tazobactam was not non-inferior, which means to say it was actually inferior to meropenem in ESBL E. coli or a Klebsiella pneumonia. So they really analyzed as to why this happened, and they found that it was not just ESBL, there were other resistance mechanisms which were going on like OXA, AMC and all. So, and there were some problems with peptide testing, which means that even though it was susceptible in vitro, it was non-inhibited in vivo. So this led to a lot of revision of the breakpoints and all those things. And so ultimately, one thing that we can learn from this trial is if you're having a very sick patient with a bacteremia, probably it is not a good choice to use a BL-BLI. So if you're using a BL-BLI, just avoid till your bacteremia is excluded. So in your sickest of patients, like this patient who came in with a bad shock, it is not a good option to use a piptas. Probably better option to use meropenem. Again, when you're using it in non-bacteremic patients, use in low inoculum infections. Okay, probably you might be okay to use it in a UTI or even a biliary sepsis. Here, it's proven that BL-BLIs are almost equivalent to carbapenems. Less severely ill patients. Again, E. coli seems to respond better than Klebsiella. Klebsiella is always a more resistant bug. And when the MICs, especially if you have a culture back, the MIC is less than 8, which means peptide is sensitive. There you can easily use it. And when you're trying to use it for a definitive therapy. Okay. So now whenever you're using, use high-end doses, and beta-lactams always work better when you use a prolonged infusion. So going back to the same case, so now at the end of it, we can sort of finalize that in this patient, if he comes to you, to your ICU or ER tomorrow, you would in all likelihood start meropenem. You might not want to add an amikacin, you might not want to add a metronidazole or a vancomycin. Okay. So that's what is the right answer. So perop, then the surgeon takes him to the theater, finds a ruptured appendix. They find a lot of pus. They do a good source control and then they come out. Again, it's very important that you tell your surgeons that they should send a perop sample for culture. See, because most of the times, as I said, even our community bugs are resistant. So unless we have a sensitivity data based on the culture, we will not be able to de-escalate. We will not be able to give a definitive therapy, right? So in this case, luckily it was an ESBL, it was non-ESBL E. coli. Actually, it was sensitive to ceftriaxone and all the other drugs. So what will we do now? So how long do we treat? So in this case, we de-escalate. You can de-escalate to either cefotaxime or ceftriaxone. They don't have anaerobic cover. So in this case, you will have to add metronidazole. Okay. So generally, and there is a good RCT data, at least from adults, which says that if you've done a good source control, if your patient is reasonably well, for an intra-abdominal infections, 4 days post-op course is the minimum course that is required for antibiotics. So if you can go back and read the reference. So basically, if you're starting with a patient with an intra-abdominal infection, very important to do adequate source control, very important to send microbial culture. Then obviously we discussed how we are going to choose our MPIC antibiotics. ICU support and all that. But remember that sometimes you might have to go and re-intervene. You might have to do a re-intervention. So what sample to send? So if they find some fluid perop, they can directly inoculate the fluid into aerobic and anaerobic blood culture bottles that we use for the blood culture. So from anywhere from 1 to 10 ml, they can inoculate. As soon as they aspirate, they can put it into the blood culture bottle and send it to the lab. So this is the basic minimum sample that they need to send. So now we talked a little bit about MIC and breakpoint. So what do we mean by MIC? So MIC is the lowest concentration of the antibiotic, which in the lab they find prevents the growth of a organism. So MIC, when you're talking about MIC, we're talking about your patient's culture isolate and what antibiotics, say for example, E. coli, piptas has an MIC of say less than 8, which means that, so that is the isolates MIC. So what is a breakpoint? These are breakpoints are standards set by the, like say European or American standards. So for each drug and bug combination, there will be a breakpoint. For example, for E. coli, I said, so ESBL E. coli, piptas less than 8 is sensitive. above 8 to 16 is called a sensitive dose dependent. Okay, so what do you mean by that? If it is sensitive, it means that you will have success with a standard dose. If I say it's intermediate or sensitive or susceptible dose dependent, then it means that if you use a higher dose, highest possible dose, or in some situations where you can use a local therapy, like in not all situations you can do it. Some places you might get away still with some success. Okay, but if it's resistant means that even if you use the highest possible dose, still you will fail. So I hope that is clear. So MIC is for the isolate and breakpoint is what is a drug bug combination and what is the sensitivity profile. So how do they do this drug sensitivity? They usually do it by 3 methods. One is a disc diffusion where they measure the zone of inhibition, or they can do a broth microdilution. So where they can see the inhibition of the growth either on a broth or on a solid culture plate. So it can be broth or agar dilution. And then this is the E-strip. E-strip means they will have a strip and then they, at the point of intersection, wherever the growth of the bacterium is inhibited, they will be able to read the MIC directly. So all these tests are acceptable and you would get the MIC based on the E-strip or the broth microdilution. So again, remember some PKPD parameters are very important, especially dealing with sepsis. Some antibiotics, your beta-lactams are hydrophilic. So you will have to use maximum doses because they will, there is a lot of third spacing that happens, okay? Whereas if you're having a lipophilic antibiotic, like say a tigecycline, here you could, they have a very good tissue penetration. So you can use your standard doses. You don't have to worry too much. So again, time-dependent and concentration-dependent actions are important. So when you're using a beta-lactam, remember that you will have to use high frequent dosing and also use a prolonged infusion because the amount of time that the antibiotic stays in the blood above the level of the MIC is very important for clinical outcomes. Whereas concentration dependent, when you're using an aminoglycoside, you want to give a single dose, which is very high dose because here the peak level of the antibiotic is what is very important. If you give an amino acid 3 or 4 times a day, it is useless. Whereas if you give a single dose, high dose, then the peak level that is achieved helps in the clinical efficacy of the antibiotic. And for some antibiotics like colistin, both are important, which means that you might have to give a loading dose, also give frequent dosing. So, so to summarize so far, so we're talking about extended spectrum beta-lactamase. So you will have to cover upfront in your community-acquired gram-negative sepsis, if you're thinking of a UTI or if you're thinking of an intra-abdominal infection or say a bad a traumatic wound or something like that, here you will have to cover an ESBL bug. And we saw where we would use a beta-lactamase inhibitor, where we would use a carbapenem. And again, please, because we have to pay close attention to what dosing we are using and what drug we are using, what are the PKPD parameters, and always send cultures, both from the blood and also from the source. If it's an intra-abdominal infection, you have to send pus from or fluid or tissue from the source. If it's urine, then you have to do the urine. So all these cultures have to be sent. Only then we can de-escalate once the patient is stable and the reports are back. So the next mechanism we are talking about is AMC. So AMC is, again, in some organisms like E. coli, Klebsiella, it is constitutive, which means that already the report will tell you that it's an AMC producer. E. coli, resistant to third generation cephalosporins, Piptas, resistant to cephalosporin sulbactam, sensitive to carbapenem, which means that it is an AMC. Direct read, you can go by the report and treat. Whereas some organisms, especially the Enterobacter, Klebsiella aerogenes, Citrobacter frundi, they have what is known as an inducible resistance. Okay, so we'll talk about that. So when you have an inducible resistance means you have the chromosome, you have the gene which can produce this AMC, but it will produce it only on exposure to beta-lactams. So on the report, these 3 bugs, no, you should be very careful. You see an Enterobacter, Klebsiella or Citrobacter, which is sensitive to cephalosporin. You have to remember that when you start using cephalosporins on therapy, the patient might fail. Okay, because this enzyme will get induced. And again, when you stop the drug, it doesn't mean that the susceptibility will revert. Okay, so if you're dealing with a very bad infection, say a sepsis, and you have these bugs, and then your best choice is to go with a carbapenem. A BLBLI also will not work based on a small pilot RCT. It was called as the Merino 2 trial. We have to wait for a larger trial, but the safest bet is to use a carbapenem. Whereas if it's a milder infection and you want to use a alternative agent which is sensitive, like I say a fluoroquinolone, you might get away with using that. Okay. In these unlikely ones, the serratia, morganella and all that, here you can be guided by the MIC. If the MIC is low, then you might still use a cephalosporin. Whereas if the MIC is high, then you might have to use a carbapenem. Okay, so that is about it. So carbapenems, we'll summarize. So these are cell wall active drugs. Again, I said they are the drug of choice in severe infections caused by ESBL or AMC. And they are again concentration dependent. They are time dependent. I'm sorry for this mistake. Okay, so you will have to give frequent doses and you will have to give prolonged infusion. And CNS penetration is good with both your meropenem and imipenem. And one of the dangerous things with carbapenem is the use of carbapenem is directly linked to resistance. So if your patient has developed a carbapenem resistant bug, it's most likely because he's been exposed to carbapenems in the past. Okay, so unlike ESBLs, which you get it from the community itself. So our use of carbapenem in the hospital will directly reflect our rates of carbapenem resistant bugs. Okay, so we have to use it with caution. There are folk drugs, but I think doripenem is not used at all. So for meropenem is what we all are aware of. Imipenem cilastatin slightly has a better gram-positive cover. And obviously we know that it has seizure potential. Ertapenem is important to know if you want to do an outpatient therapy. So it is once or twice daily dosing. So again, we use it for de-escalation. It does not cover Acinetobacter and Pseudomonas. Suppose you have an AMC E. coli, okay, you causing a pyelonephritis or a renal abscess where you need a prolonged therapy. No other oral options available. So you have to use a carbapenem. In that situation, rather than using meropenem, you might use ertapenem because ertapenem is like a de-escalation there because it doesn't cover Acinetobacter or Pseudomonas. But again, it's not a drug which you would use upfront in an ICU. So with that, we move on to the third part, which is the carbapenem resistant Enterobacteriaceae. So this slide I have taken from my professor, Dr. Ram Gopal Krishnan, because I think I can't summarize it better. So if you want to know what are the principles in treatment, okay, the first thing I think very, very important, if all of you have attended the first lecture, the most important thing when you start treating a patient is whether it is a colonization or a true infection. So rather than treating a culture report, we should treat the patient and his symptoms. Okay. And when we are talking about MDR gram negatives, rapidity of treatment and rapidity of appropriate treatment is what is very important. So you will have to determine sensitivity as soon as possible. So as much as possible, you should use molecular tests so that you can identify the bug as well as the DST. There are so many methods available and we should be able to use them. Again, knowing the exact molecular mechanism is now becoming very important, isn't it? Whether it's an MDM or an OXA, everything is important because the drug that you're going to use depends on the molecular mechanism. And again, knowing the exact MICs is important. It's no longer just reading whether it is sensitive or resistant. You have to see what is the MIC and then learn to look at it. So we'll talk about it further. And then using proper doses, paying attention to the PK/PD parameters. We'll talk a little bit about combination therapy later, but generally use it for your high risk and your immunosuppressed hosts. And this I can't stress enough. It is not just antibiotics. You have to use adjunctive therapies. So unless you do a good source control, unless you try and come off.
Thank you.
Unless you reverse immunosuppression, you're not going to be able to treat the patient well. So what about the CRE surveillance data in India? So this is again from the ICMR report. So if you look at it, if you look into the ICUs, the ones in red are the ICU ones. So E. coli and Klebsiella, 2 bugs. So meropenem sensitivity is only about 30% in Klebsiella and about 60% in E. coli. Okay, so it's not 100% sensitive. So remember that your ICUs can have such a high rate of meropenem resistance. And other fluoroquinolones, cephalosporins, all are virtually not usable. Even colistin, if you look at it, 100% in E. coli, but only about 90% in Klebsiella. So there is a problem of carbapenem resistance in our Indian ICUs, which we all need to be aware of. So what are the carbapenemases in Indian context? So here again, as I said, KPC is not a big problem at all in India. Most of the Western guidelines, most of the Western literatures will talk about antibiotics for KPC. In India, most centers do not report KPC at all. So we can almost forget it unless your center has a problem with it. So MBL and OXA48, these are the two main enzymatic mechanisms that we need to worry about. And this can be detected by many ways, by either phenotypic or genotypic methods. I think your microbiologist should be able to help you with that. So drugs for CRE, again, these are the drug options that we have: polymyxins, fosfomycin, TG-cycline, ceftazidime, avibactam, plus or minus aztreonam, and the other conventional ones. So what about polymyxins? So polymyxins include two classes, two drugs basically, called colistin, which is polymyxin E, and polymyxin B. So colistin is, as we all know, is a pro-drug, which means that it has to be converted into the body, which is again taken as a slight adverse compared to polymyxin, where no conversion, it's a direct acting agent. Colistin has a renal elimination. And in most studies, colistin, the major problem seems to be that it is highly nephrotoxic. The other major thing is it has a very variable PK/PD. So between different formulations of colistin and between one person and the other, there can be a lot of variability in the levels that it attains in the blood. Okay, so that's why it's very important that you have to use very high standard loading dose and proper intervals of dosing and frequent dosing, and stick to the highest dosing. Otherwise, you will not know what levels your patient will achieve. And which means that if it's subtherapeutic, it is going to breed resistance. That's why colistin is a drug which is very prone to develop resistance, because of this inter-individual differences that happens. But paradoxically, actually, in a patient with renal failure, the steady state is more reliably achieved. Okay, because it's renally excreted. When the renal elimination does not occur, the drug levels in the blood are more reliable. Polymyxin, on the other hand, is probably less nephrotoxic. It's not as well studied as colistin. So we think, but in clinical practice, that's what we see, probably less nephrotoxic, but neurotoxicity we do see now and then. Here, the PK/PD differences are still there, but not so bad as colistin. And there is no dose adjustment that is needed in renal failure. So that is one of the advantages of polymyxin B. But polymyxin B does not penetrate renal parenchyma. That is something that we have to remember. So if you're thinking of a UTI, a bad MDR gram-negative pyelonephritis, you should not be using polymyxin B. You should rather be using colistin. So polymyxins, what is the latest guidance? So till recently, we all used to use this as a last resort drug for CRE. Then ceftazidime avibactam came in, and then there is a lot of cry and furor about it. But then all the Western guidelines seem to shift from IDSA, XMED, all of them shifted towards using these novel BLBLIs rather than using polymyxin. Actually, there is a problem with polymyxin MICs, in the sense the breakpoints that are given by CLSIs only gives an intermediate and resistant breakpoint. There is no sensitive breakpoint because of the way the wild type strains have the MICs. There is a bisecting of the MIC curve. So that's why you can't have a sensitivity. As per their guideline, you can't have a sensitive strain at all unless you're using supratherapeutic doses of colistin, which will actually kill the patient because the kidneys will fail. So this is the status as far as polymyxins are as per the Western guidelines. Obviously, in India, we still have to use it because we don't have many other beta-lactam, beta-lactamase inhibitors. Like, for example, the meropenem vaborbactam, imipenem relibactam, all those things don't work in India because KPC is not a big problem for us. So our problem is oxa and NDM, for which we don't have much drugs. So we still have to use polymyxins. So what can we do is, see, if you have an alternative agent which you can use in your population, so if you have a sensitivity report which seems to have a reasonably alternative agent, then you might use that. Or if you're use in high doses and use in combination, especially if the patient is sick, especially if the MIC is more than 0.5. So colistin MIC more than 0.5 should give you a caution that the drug might not work. And generally, it's a good option not to use it in pneumonia because it doesn't attain good levels in the lung. Between the two, colistin is what you would use in UTI for reasons that I said earlier. And this use of this nebulizers, routine colistin nebulization for all patients in the ICU who have an MDR bug, is a very bad practice because it can breed resistance to colistin. As I said, colistin, there is a big problem with emergence of colistin resistance that we are seeing in India. So we have to be careful that we don't abuse this colistin nebulization. In a very die-hard situation where you don't say you have a bad carbapenem resistant Acinetobacter, where you don't have any other option. If you want to use it, use a jet nebulizer and use it along with systemic therapy so that the drug levels are achieved. And this is among the two, colistin is the one which is preferred for an intrathecal therapy. So moving on to ceftazidime avibactam. So this covers AMP-C, it covers ESBL. Obviously, we don't want to use it to cover these two. We want to use it to treat carbapenemase in India. The Western guidelines promote this as a carbapenem sparer, but we don't have much drugs for carbapenemase producing organisms. So we should probably use it only for your oxacarbapenemase. It doesn't have action against Acinetobacter. It doesn't have action against anaerobes. So you have to give added cover. And it doesn't have action by itself on metalabetolactamases. So you will have to combine it with aztreonam, which means that in this case, if you're using ceftazidime avibactam plus aztreonam, the avibactam will take care of all your ESBLs and all that. Aztreonam, as I said, does not have action against ESBLs, but it will cover your MBL. So that is how that drug is used. The ceftazidime component is actually not useless in that synergistic combination. So when you're using this two drugs together, remember that your lab has to do what is known as a synergy testing. So if you have a E. coli or a Klebsiella, which is resistant to ceftazidime avibactam, which is resistant to aztreonam, okay, that's how your report will read. Then the lab will put these two drugs together and test whether the drug works. These two drugs together work. And then they will say that the growth is inhibited when these two drugs are used together. So that is called a synergy testing. So unless your lab gives you that data that the synergy testing is positive, you cannot use ceftazidime avibactam plus aztreonam just like that, because most of the times, like say 15 to 20% of the times, this synergy testing might be negative. Okay, so it's not just based on the finding an NDM gene on the expert CABA or something like that. It is also looking at the synergy testing to make sure that your drug combination is actually working. So for NDM Klebsiella, it's a very good drug, especially if synergy is positive. In NDM E. coli, you could have problems because penicillin binding 3 proteins can inactivate aztreonam. So that can be a lead to clinical failure. So that is, again, it's not a very good drug for NDM E. coli. It might not be a good drug for Pseudomonas as well, because clinically, MICs are found to be high and other resistance mechanisms will limit its usage. So in India, if you want to use ceftazidime avibactam, probably the best place you can use it is for an OXA positive Klebsiella or E. coli, or an NDM Klebsiella if you know that the synergy is positive. Okay, so which means that literally we are telling you that you will have to know the genetic mechanism as well as the synergy testing mechanism as well as the MIC. So this is how complex it is, isn't it? So it's not just using ceftazidime avibactam empirically or even otherwise and then just living with it. So anti-sero drugs, other drugs that we have is tigecycline. This is a glycyl cycline and it's a very highly lipophilic drug, and this drug has a high volume of distribution, which means that it doesn't stay in the blood at all. As soon as you give it to the patient, it will diffuse into the tissues. Okay, it has a very broad antimicrobial spectrum, gram-negative, gram-positive, anaerobes, everything it covers, but it doesn't cover Pseudomonas. Okay, so that's very important to remember. And generally, it is considered not a good drug for a primary bloodstream infection, like line-associated infection, because I told you it doesn't stay in the blood, it diffuses into the tissues. Again, it's for HAP and VAP, studies have shown that if you use it in the standard dose, the mortality is high. So, but when they tried using the high dose TG, then the mortality was not high. So there is generally a reluctance to use it in HAP or VAP unless you don't have any other option. Again, it's not a very great drug for meningitis. So where it is approved is, as I said, intra-abdominal infection. So you have a patient who is admitted to the hospital, and then during a hospital stay or after a surgery, prolonged recurrent antibiotic exposure, he develops a new IAI, or if it's a complicated SSTI, where it's polymicrobial again. So here, in these two situations, it is a good drug. And then if you're using it for Acinetobacter, carbapenem resistant, we have very few drugs. TG is one of them. So again, here, when you're using, try to use high dose TG. So again, there is no guideline for high dose TG in children, but probably you would use the highest possible dose. In adults, it is double the recommended dose. But then in children, probably you would use the highest possible dose. So nausea and vomiting is a very important side effect. And again, when you're using TG, remember that you have to look at the MIC. If the MIC is less than 1, it's more likely to work. If it's more than 1, then you will have to think whether you want to use it in combination or you want to look for alternative agents. The other agent that we use often is fosfomycin. So this again acts by inhibiting your cell wall synthesis. It's again a time-dependent cidal action. Again, broad spectrum cover. It covers CRE, MRSA. Most anaerobes, some anaerobes like Bacteroids are not covered. It's a very good drug for CR E. coli in India. That's what I can tell you. Most centers have very good sensitivity for their CR E. coli to fosfomycin. Okay, but it's not a good drug for CR Klebsiella because CR Klebsiella and other Enterobacteriaceae have what is known as a FOSA gene. This FOSA gene will automatically inactivate this drug. So even if it is sensitive in vitro, it is not a good drug in vivo. Okay. So Pseudomonas, Acinetobacter, Stenotrophomonas, Bacteroids, all these do not get covered by fosfomycin. So again, important to remember, you cannot use it as a single upfront agent if your unit has a lot of problems with both CRE as well as say Acinetobacter. This is a very good drug for meningitis. So especially if you have a neonatal meningitis, MDR, E. coli and all those things, fosfomycin has very good CNS penetration. So it can be used to treat meningitis. You have to keep an eye on the sodium when you're using fosfomycin. So we'll move on to another case. It's a 3-month-old ex-preterm respiratory distress syndrome, prolonged hospital stay, already treated for an ESBL sepsis with meropenem. So now was currently admitted in an outside hospital for what looked like a viral respiratory infection and already received all these antibiotics, meropenem, vancomycin, azithromycin, oseltamivir, empirically for a prolonged period of time. Just before transfer, this child had developed a new fever and shock and already received cycline for 2 days. This child has a C line in place, has whiteout lungs, is actually getting shifted for ECMO probably. And then this child, if you look at it, this only had a Klebsiella pneumonia ESBL in a respiratory culture, had a metapneumovirus positive, and had blood cultures which were always sterile. In spite of all this data that we had, still this child got all these broad spectrum antibiotics, which is something that I hope we will avoid. That's the point of you doing all these webinars and teaching sessions. So if you have something like this, you should be able to de-escalate. What is the point of giving oseltamivir for a metapneumovirus? Why should we be giving a vancomycin when there is no gram-positive bugs? When we use antibiotics like this for a long time, we are going to breed resistant bugs in the patient. So now let's see what happened to this patient. So this patient came in, was thought to be in sepsis, continued on mechanical ventilation. So we drew blood cultures and we also sent a beta-glucan assay. So we thought that the probable infection could be a CLABSI or a VAP because the line was in place, the lungs were white out, difficult to say whether there was a pneumonia breeding there or not. And again, invasive candidiasis. Obviously, child has had such a broad spectrum antibiotic exposure with a line in place. So now what option do we have? This child is already on polymyxin and TG and still not improving. So do you want to continue that and wait? Or should we add phospho? Should we add empirically ceftazidime, avibactam, aztreonam? What can you do? Okay. So this is a real life situation which we face often in PICUs, isn't it? So what are we going to do? So in this case, obviously because now center ID is involved early, so we had no choice, but we said that we will not be able to continue polymyxin and TG cyclone. We had to use ceftazidime, avibactam plus aztreonam. We don't like to use it empirically, but in this case, we had no other choice. So we started that, we gave gram-positive cover. We also gave echinocandin cover for an invasive candidiasis. But the only good thing is the blood cultures flagged within 24 hours. So at which point, the first thing we did was we stopped the teicoplanin. And then we immediately asked for both MALD ID as well as CARBAR. So MALD ID will take only 6 hours. So the same day evening, we knew that it was Klebsiella pneumoniae. Expert CARBAR also takes only 6 hours. So we knew that it was an OXA48. So now you know that you can use ceftazidime avibactam pending your sensitivity. Okay. So here you don't need aztreonam. You just need ceftazidime avibactam. So you could also do the BCID panel, which will give you the same data in one go. Okay. So if you use the BCID panel, I'm sorry, I didn't put that panel last time. I think I showed it. So it will show you both the Klebsiella pneumoniae as well as the OXA48 gene. So in a single test, but it's a very costly test. So that's why we didn't do it. So we did this and then we got the reports. Then we also knew that the beta-D glucan was negative the next day. So immediately we stopped micropunction. So within 24 hours, we almost 24 to 48 hours, we are able to rapidly de-escalate. Though you're starting very broad, if you use these molecular tests, you can rapidly de-escalate. The next thing I want to say is stress on blood cultures. I think I told this the last time. Again, unless we are doing good volume blood cultures, we are not going to see culture positivity. So this patient who was in the outside hospital had so many blood cultures, but none of them grew anything. So the reason was probably they were not culturing enough volume. So how do we use the expert CABR? So if you have a suspected sepsis, blood cultures are drawn and empiric antibiotics. So if you have a gram-negative flagging, remember that when you have, when you're using expert CABR, you need to have some way of getting the ID of the bug. That's important because for Enterobacteriaceae, it's different and non-Enterobacteriaceae different. Enterobacteriaceae predominantly have carbapin enzyme-mediated mechanisms. So you can be guided by the report. So if the CABR is positive, if the patient is not already on a carbapenem-resistant cover, you will escalate. Otherwise, if they're already there, then you will continue. And then you will always initiate infection control measures. If the CABR is negative, then you can safely, most of the times, de-escalate. Okay. Whereas non-Enterobacteriaceae, like your Pseudomonas, Acinetobacter, they have non-enzymatic mechanisms, sporin channels, efflux pumps, and all those things. So there, you can only if the report is positive, you can be guided by it. But if the report is negative, you cannot de-escalate. Okay. So remember that if you're using this CABR, you have to have, see that roughly if you want to say these are lactose fermenters, these are non-lactose fermenters. But again, not very good clues because as I said, some of them are late lactose fermenters and then they will get picked up as non-lactose fermenters. So there's a lot of confusion. So, but then roughly that is how it works. So generally, if you have access to MALD and if you have access to ID, then it becomes easy. Rapid ID, it becomes easy. Okay. So this child then finally had a Klebsiella pneumoniae in blood, which was resistant to TG, sensitive to colistin with an MIC less than 0.5, but TG, you look at the MIC is 2. Okay, so it was useless. So that was the empiric therapy that this child got. Somehow this child did not get better. So this child was treated with ceftazidime avibactam. See, so subsequently the ceftazidime avibactam sensitivity was also reported. Sorry, I didn't get that picture. So it was sensitive and we continued it and the child improved. Okay. So again, though I've used ceftazidime avibactam empirically in this child as a thing, just remember that this is a very good paper, recent paper. It says that we should not be using ceftazidime avibactam is now no longer a generic. No, so many other brands are coming up. So it is a last line antibiotic, and then you should only use it as targeted therapy. The more you use it as empirical therapy, you're going to use this precious antibiotic because there are going to be other resistance mechanisms which are going to develop. The other thing I will briefly touch upon is phenotype gene dip. Sometimes what happens when you do a CABR, you find a gene, but the sensitivity does not show resistance. It is a sensitive bug. Or it's the other way around. You will sometimes have a resistant on the phenotype, but the gene will not be picked up. So what are the possible mechanisms? Sometimes you have a polymicrobial growth. So when you have a polymicrobial growth, generally the genetic tests are not good. Okay, so it might pick up on one colony, it might not pick up on the other bug. So that is one reason. Or there can be heteroresistance. Heteroresistance means there are multiple subpopulations of the bacteria which have different resistance mechanisms or different sensitivities. Or there can be other mechanisms of resistance. So it might not be an enzymatic mechanism at all. It can be a porin or an efflux or an FC which might not get picked up on your genotypic test. Or there can sometimes be unexpressed, but it is silent. It is not expressing itself. So which means that it might show as a sensitive thing on the DST. Again, this is how we get data every 3 months in the main hospital and also in the children's hospital. See, they give us a split up as it is a bad carbapenem resistant. What are the antibiotics which are likely to work? So if you have some kind of working mechanism like this, then it becomes easy. So here, when I look at it, I know E. coli, fosfomycin has a good chance of working. Whereas ceftazidime avibactam alone will not work. Whereas if it is synergy, only 87% of the times it will work. Okay. So Klebsiella, it's like 50% times this will work. So this kind of data is very important that the lab generates and shares with us. This is an example of an extended antibiogram, isn't it? So if you have something like this, you should have something like this to guide your treatment in your ICU, both empiric and specific. So moving on, I'm sorry, this class is a little long because there's quite a lot to cover. I hope I can go on. So the next part is Acinetobacter. So Acinetobacter, again, the most important thing that we want to worry about is Acidomyta baumannii. Okay, so species level identification. The lab cannot tell you Acinetobacter species. That doesn't mean anything. So Acinetobacter baumannii is a classic pathogen. Other things like IO5, nosocomialis, usually they are contaminants and you can ignore. So in Indian data, again, Acinetobacter baumannii has very high resistance. Okay, so universally high resistance. So it seems to be coming down, still it's high. Whereas Pseudomonas aeruginosa is usually a steady level of resistance. Huh? Okay, so it's not a drug resistant Pseudomonas is not a very big problem in India in most units. Okay, some units really do have a problem, but not mostly. So a carbapenem resistant Acinetobacter, the principles of therapy again. So Acinetobacter baumannii itself, it's not a very virulent bug like Pseudomonas. Pseudomonas is a very virulent bug, but Acinetobacter is not. So most of the times you will pick it up on a respiratory culture or a wound swab culture. So very, very important that you have to really make sure that it is a true infection and not a colonization. That's very important before you start treating all your Acinetobacter baumannii. So it's often multi-drug resistant. And usually it's always when the patient is in the ICU for say a third or fourth week, that's when you start getting this. Obviously some ICUs will have it upfront, but most of the times it's a sick patient who already has a high mortality. So monotherapy is what is advised in mild infections. Okay, whereas if it's a severe infection, even though there is a randomized trial, a combination therapy does not seem to be better than monotherapy in severe carbapenem, in severe cramps. Still, the guidelines recommend combination therapy because the drugs that we have are not so great. So you can't use colistin with either phospho or rifampicin or meropenem. That is straight away out. Okay. Phospho is not a good drug for Acinito. Rifampicin also doesn't seem to work. And meropenem in India definitely useless because most of the times the MICs of meropenem are very high, 628, something like that. So where you will not have any added benefit even when you're using it with colistin. So the options that you have for Acinetobacter are only this, colistin or polymyxin B, sulbactam by itself, which again is available in India. But somehow I couldn't get a pediatric specific dosing for this. Okay. So minocycline, tigecycline, and Cotrim. So I think most of the times we are comfortable using colistin. We have used tigecycline. So in milder infections, you can use Cotrim if it is sensitive. Okay, so these are the options for a Acinetobacter. Okay, Pseudomonas aeruginosa again is a very bad pathogen, especially in neutropenic patients and cystic fibrosis. Sometimes children come in with this. So they can have differential sensitivities. That is again important to know. Pseudomonas is not a enzymatic producer. Carbapenem is most of the times it is not. It can produce NDM, but most often it has efflux pumps, sporin channels, and all those things. So it can sometimes be. So these are the various ways. So it can sometimes be sensitive to piptas, but resistant to imipenem and meropenem. It can be otherwise. It can be resistant to piptas, but sensitive to imimero. Or it can be even sensitive to ceftazidime, but resistant to mero. So it can show these kind of funny sensitivities. But if your lab is good, then you can be guided by those sensitivities. Okay? You can usually dose of the resistance mechanisms. So generally, earlier teaching used to be that you should always use beta-lactam plus aminoglycoside. But as no longer it is proven to be important. So you don't have to routinely do an aminoglycoside because, as I already said, the adverse effects are higher. So if your carbapenem is resistant, but if your beta-lactam is sensitive, again, just use high doses or prolonged infusion. But still, if you have clinical failure, then you will have to think of other things. So again, it can develop resistance on therapy. So please have a watch out. When you have a Pseudomonas aeruginosa, you'll always have to keep an eye for clinical failure or microbiological failure. So DTR Pseudomonas aeruginosa, this is the new term. So difficult to treat, okay? Resistant Pseudomonas. So it is non-susceptible to cephalosporins, BLBLIs, Astrium. Astrium is a very good drug for Pseudomonas if it is sensitive. Okay, so if it is sensitive on the report, you can use it. Meropenem, imipenem, ciprolivo. So almost all these drugs are gone. Then what do you have left? You only have polymyxin in India. Ceftazidime, avibactam plus Astrium, as I said, though most of the times it doesn't work in India because there are other resistance mechanisms. As I said, it's not just an NDM, it can be a porin or a efflux pumps, aminoglycoside. So very limited options. So luckily, This is not a big problem in India. Maybe once in a year we see something like this. So it's okay. We get away with it. So TG and phospho both are very bad drugs. Okay, phospho, though the European guidelines say that you can use it if it is sensitive, generally it's not a very great drug for TG. Has absolutely no activity against Pseudomonas. So ceftolozane, tazobactam, these two drugs may work, but again, they are not available in India. Once or twice we have tried importing and using if we had a very die-hard situation. So I'm almost coming to the end of this talk. So combination therapy in gram negatives. Okay, so what and when to use? So you always want to use combination therapy in critically ill, okay, very bad shocky patients, immune compromised patients. Okay, don't want to use it when the patient is stable and if already you have good source control done, everything is done. Routinely avoid using combination therapy. So you would want to use it when you want to cover many bugs or resistance mechanisms based on your diagnosis. So for example, if you're using a colistin-based regimen for a bad intra-abdominal infection, remember that it will not cover GPC anaerobes, which means that you will have to give extra cover for those things. So these are the ways in which you will want to use combination therapy. But routinely adding amikacin, metronidazole, vancomycin, routinely failing to de-escalate, all these things are very bad practices which will lead to resistance. Again, a word on site-specific therapy, very important. So when you're using when you're dealing with a MDR gram-negative pneumonia, again, remember that it's important to avoid polymyxins, avoiding using only nebulized antibiotics, avoiding aminoglycosides. If you're using pyelonephritis, generally, again, don't use tigecycline, polymyxin B, oral phosphomycin. Oral phosphomycin will not go into the renal parenchyma. Okay. Amikacin monotherapy is only acceptable in stable patients, not in your shocky patients. Meningitis, again, both your beta-lactams and carbapenems go well. We know that BL-BLIs don't penetrate. Drugs which have good meningitis cover are phosphomycin, chloramphenicol, cotrimoxazole, minocycline. They all have. So, for example, if it's a bad carbapenem-resistant Acinetobacter, you might want to use a minocycline if it is sensitive. Sometimes we have used chloramphenicol for CR club meningitis. Phospho for your CR E. coli meningitis. Okay, so depending on the bug, you can use these drugs based on the sensitivity. And polymyxins generally better avoided. The only way you can use it is probably intrathecal. Okay. Again, somebody asked me about duration of therapy. So to reiterate, most of the times, whatever we're talking about duration of therapy, it's not very different from say a resistant bug and a sensitive bug and all that. So as long as your patient is improving well, you can follow your standard guidelines for duration of therapy. Okay, so it's becoming shorter and shorter. So for VAP, it's 8 days. For a gram-negative bacteremia, it's only 7 days, especially if the line is out, patient is stable, just decide to stop. COTI is only 3 to 5 days. The SSTIs are only 5 to 6 days. Okay, intra-abdominal infection, already I told you, 4 days. Pyelonephritis, 7 days. So all these things, just most of the times, the patient is already stable by this time. You've treated adequately. Just feel free to stop. The last part is the non-fermenting GNB. I'm going to talk only about, see, these are the major ones, Acinetobacter, Stenotrophomonas. So I'll only talk about Stenotrophomonas because that is something that we often see. So it is inherently resistant to aminoglycosides, polymyxins, and beta-lactams. So only drugs which will work are probably Cotrim, ticarcillin cavlonate, cefidericol, levofloxacin, minocycline, and chloramphenicol. Ceftazidime, I will tell you about it later. It can cause a whole lot of syndromes, okay? So the treatment is mild infections, Cotrim, minocycline. These are the options that you have, okay? But of these, probably cotrimoxazole is what we standardly use. Minocycline can also be used. Ceftazidime should not be used to treat Stenotrophomonas maltophilia, regardless of whether it is sensitive or not, because there are intrinsic beta-lactamases. So even though your lab will report, in our labs, we've asked them not to report it. So even if the ceftazidime is sensitive, because if it gets reported, then people use it. So don't use ceftazidime to treat Stenotrophomonas, even if it is sensitive. Okay. So moderate to severe infections, usually you can either do 3 strategies. Either you do an upfront combination with Cotrim and Mino, or you can start with Cotrim. Most of the times, this is what we do. We start with Cotrim, and if the patient is well, we leave it there. Or if not, then we try and add another agent. By which time your sensitivities are back. Because again, most of the times the sensitivities are so different. So if you have started with Cotrim and then you know that it is sensitive to Mino, then you might want to add on Mino if your patient is not improved by then. Remember that ceftazidime, avibactam plus aztreonam covers Stenotrophomonas. Okay, so if you've already, if you have some other bug which you're treating with ceftazidime avibactam aztreonam, then you might probably use the same to treat Ctenotophoma, but don't use it always to treat Ctenotophoma. It is not the best drug. Cotrim is the best drug, but you can use it as a last resort when other agents are not available. So to summarize, gram-negative resistance is an issue in India in both the community and the hospital level. So it's not just that you will think of gram-negative resistance in the hospital. From a community sepsis also, you will have to think of and cover. An empirical choice depends on host, depends on the epidemiology, depends on the site of infection. I told you, like pneumonia, you will choose this. Intra-abdominal, you will choose this. So it's important that you be guided by the clinical syndrome and use combination in unstable and critically ill and immunocompromised patients. Okay. And if use molecular methods whenever you can, so that you can give early targeted therapy. So that improves patient outcomes, reduces your chance of resistance development, and de-escalate at always at 48 to 72 hours. So if you have not grown a resistant bug, patient is stable, just de-escalate. Don't continue to give a lot of empirical therapy like broad spectrum combination and all that. If your patient has improved at 40 to 72 hours, we should have the courage to stop and give the minimal possible cover. Okay. Source control again is very, very important if you want to have clinical sepsis. So with this, I'll stop and I'll invite you all to the annual SITSCON meeting, which is going to happen in July in Chennai. So we have a separate pediatric ID track on the Sunday, half a day session. So you will learn about MDR bugs and a whole lot of other neonatal sepsis and all those things. It will be interesting. I welcome you all to attend this conference. Thank you. And I'll stop and take questions.
Thank you, Dr. Vidya.
Yeah.
Stop sharing.
Yeah.
There are some questions in the chat box. If you could answer that. You are able to view the chat box?
Yeah, I'll do that. I'll take up one by one. So the first question is, should we cover enterococcus empirically for sick intra-abdominal infections? See, as I said, no, like enterococcus is generally a healthcare associated pathogen. So most of the times you will only want to cover for it in anybody who has had a recent hospital exposure or recent cephalosporin exposure. Cephalosporins are intrinsically resistant to, enterococci are intrinsically resistant to cephalosporin. So those two, some trigger factor you have. So normally, again, if it's a community-acquired enterococcus, it's going to be only Enterococcus faecalis, which will be covered by your, say, your PIPTAS or your carbapenem or something. So you don't have to do an extra added cover routinely, unless you're thinking of a healthcare-associated situation, or, yeah. So those are the conditions, okay, where you will have to cover enterococcus. So routinely, you need not cover in a mild to moderate infection or a community-acquired infection. You will cover it in a healthcare-associated infection. What is the seriousness of Stenotophomonas maltophilia in blood culture sensitive only to septum? See, Stenotophomonas maltophilia, if you find in blood culture, you cannot ignore. It is a nosocomial, classic nosocomial pathogen. If your patient is sick and you have decided to send blood culture and you grew it, you have to go by it. They can be, if it is sensitive to septran, you have, is it a continuation of the same question? Sensitive only to septran and
question.
is allergic to cotrim.
I think the same person is asking the question. I think the first question was that if it's just septran, is it really important to consider that? The second question is if he's allergic to septran, what else can?
Yeah. So see, Cotrimoxazole is the drug of choice, as I said, for treating Stenotophomonas. The other options you have are, I don't know if your lab did check for minocycline, levofloxacin, as I said. So these are the other agents. So the extreme thing that you can use is azithromycin, as I said, ceftazidime avibactam plus azithromycin. Maybe your patient is one of where you don't have any other choice, then you might have to use. Don't use ceftazidime alone, because it produces, as I said, beta-lactamases. So you will have to use, if at all you're using, you should use ceftazidime avibactam plus azithromycin. But important to look into the other choices, minocycline, levofloxacin, and all that before you go on to this one. So the next one is your experience with Burkholdt area. See, I'm sorry, I didn't have enough space. I was going to do Stenotophomonas and Burkholdt area, but I thought it would be too much. See, Burkholdt area, Chenocapacia complex. No, that is very common in nosocomial. Burkholderia pseudomela is melioidosis, which is a community bug. Okay, they both are different. But generally, Burkholderia is a non-fermenter, almost like your Pseudomonas family. But intrinsically, they are resistant to your beta-lactam beta-lactamase inhibitors, colistin. It will not work. So what works is usually ceftazidime, cotrimoxazole, and carbapenem. Okay. So these three, if your lab says that Burkholderia is sensitive to colistin or sensitive to, ciprofloxacin or aminoglycoside, that means it's wrong. It's a wrong report. So they are intrinsically resistant to many antibiotics. So if you have ceftazidime sensitivity, you can use meropenem. You can use if it is sensitive. But if it is already ceftazidime sensitive, you can safely use ceftazidime itself. Don't have to use meropenem always. Okay, Cotrim is a good choice if it is sensitive. So remember those things. Yeah. Burkholderia is usually again, what do you call? It's a respiratory. Sometimes in this cystic fibrosis patients and all will come with Burkholderia in the respiratory isolate. So sometimes it can be difficult to eradicate also. It can cause nosocomial outbreaks. So yeah. Anything else?
I think that's all in the chat. If anybody else has any questions, please unmute and ask.
Was it too elaborate? Last time there were a lot of questions because I think it was more shorter talk. But this, we had to do all this because otherwise I can't finish in one class.
Well, this was quite good. So,
Anything that you want me to clarify, like anything I went fast somewhere. I think I tried to do it slow, but any part of the talk was good.
Can I ask a couple of questions? Like you had mentioned about the ICMR publishing reports every year about the resistance, and you said that you will not be using certain drugs with resistance. So about what percentage of resistance do you think considering using other drugs?
See, generally most guidelines are 10 to 20%. No, so suppose if 10 in the extreme, like in the sick patients, I would say 10% is a safe estimate. Suppose if your ICU say 10% isolates are say resistant to colistin or something, then you should not be using colistin as your first choice. So in ICU, I think it is safe to say 10%. The 20% will be for the wards or something like that, where you have more time to act on the patient.
As you said, the common thing was the combination of adding aminoglycosides to drugs. So the question I want is, does aminoglycoside add anything to BLBLS?
See, if you have some people look at it like a carbapenem sparing. No, if you use piptas and amino, if most of the times piptas has an average of 60 to 70% sensitivity or something. So if you're using it in a stable ward patient where you're going to be using piptas, you might as well use only piptas. Okay. Whereas if it's a very sick patient, you will already be using carbapenem. So this piptas plus amikacin combination is generally it's not going to be really great. Like in an ICU, you're not going to use that combination. In the ward, it is extra. Like you don't want to use 2 drugs to treat a stable ward patient. So that's why most of the times we don't advocate adding aminoglycosides. Also because we don't routinely check the levels. Like unlike the West, where they have carefully they measure the aminoglycoside levels and make sure that the patient doesn't go into ototoxicity and all that. We don't have that kind of mechanism. So I think safely excluded.
Okay, the chat.
Streptococcus.
The empirical antibiotic slide.
Yeah.
Show that.
So may I ask one question, ma'am?
Yeah.
I think it's an elaborate presentation of gram-negative bacteremia or gram-negative sepsis. We really learn a lot with your presentation. So one query is that sometimes we do in ICUs like mini-bal or bronchoalveolar lavage, and we send for this biofire, and then multiple organisms are coming. So how to take into consideration those multiple organisms with different genetic susceptibility to treat those patients on that basis?
First of all, we have not introduced this panel in our hospital for precisely the same reason, I think. See, one thing I want to know is there a culture correlation? Do you find the same organisms growing on culture?
No.
Yeah. So then we have to see, isn't it? Because the PCR, I know that the biofire also gives you some amount of colony count and all that, gives you an
Correct.
approximation, all those things. But the PCR, having said that, is a PCR. It will even pick up, say, a non-viable bacteria or anything like that, isn't it? So there is a problem that you will be over-treating.
Sorry. Yeah, absolutely, ma'am. And that's how we are getting something like H. influenzae, Streptococcus pneumoniae, and all these organisms are coming, which is possibly are not pathogenic on that particular stage.
I am actually, H. influenza pneumonia, at least I can understand. See, these are classic pathogens that you would see in CAP in children. They might be easily killed by antibiotics. Okay. So
Correct.
those are okay. But if you're talking about, say, resistant, say an Acinetobacter or a Stenotomonas routinely getting picked up, but does not grow on the culture. Okay.
Correct.
Those things are where I'm worried about, because you will be using high-end antibiotics to treat, and you will be treating a lot of patients for pneumonia. Okay. So if you're just for a community acquired bug, probably it is okay, because anyway, you will be treating a patient minimum with a beta-lactam, which will take care of your H. influenza and say pneumococcus. But if you're thinking of a nosocomial pathogen, I think it's better to correlate with cultures. Upfront, you might treat, but once your cultures are back, then correlate with that and decide to come down.
Okay.
Yeah.
Thank you.
Yeah. So somebody wants to see the empirical antibiotic slide. I'll try sharing. I'm sorry, I have to see. Was it this one? I'm not sure which one. That must be the one, no? Yeah.
We can ask because it was posted to.
I think that was the only one, yeah.
Phase 1 plus only. So if the person was posted.
Yeah, he said thank you. Yeah.
Yeah, see?
Yeah.
And that is the next only questions.
Yeah, I think we'll do that in the next class. Dr. Vinita, you can join me for the next talk on gram positives. Okay. So somebody wants me to de-escalate, elaborate a bit on de-escalation. Okay. So what do we exactly mean by de-escalation? So we said that when we're doing empirically, we have to cover a whole lot of bugs because we don't know what we are dealing with. The child may be sick, critically ill and all that. So we want to cover gram positive, gram negative, based on what the syndrome is and how sick the child is. You might be using a broad spectrum. You might be using, say, carbapenem. You might be using, say, sometimes you might be adding a vancomycin. So it might be one drug which is very broad, or you might be using 2 or 3 drugs. Okay, depending on the situation. So now that is when the patient is sick. So at 48 hours or 72 hours, what happens is most of the time your patient is stable, and you also have your blood culture already coming back. So if your blood culture, for example, you have a patient who's admitted with a severe, let me say this patient that we talked about, no, intra-abdominal infection, right? This patient, we gave a meropenem to start with. Okay. But then after 48 to 72 hours, the blood did not flag in this child, but at least somebody had operated and done a blood pus culture and all those things. And that showed that it was not a resistant bug, isn't it? It was only a sensitive ESBL, sensitive E. coli. Let's even say it was an ESBL E. coli. Okay. In that case that I presented, let's say it was sensitive only to piptas, cephalosporin sulbactam, and then meropenem and all those things. So still, if you are coming down from a broad thing like a meropenem to piptas, okay, meropenem is a carbapenem. So the more carbapenem you use, the more resistance is going to develop. So you want to use something which is a carbapenem sparing. So BLBLIs are called carbapenem sparers. So you're going on from a very broad one to a narrow one. Okay, so you're coming on from carbapenem to a BLBLI. Or say, if for some reason, if you are decided to use piptas plus amikacin in the upfront, then when you see this, then probably you will knock off the amikacin and just do the piptas. So this is very easy when we have a culture positivity pack. Okay, but there are situations where your cultures do not become positive. Okay, suppose let's say that you had a patient. This is very easily done with gram positives. Suppose you have given a vancomycin, the child has come in with some febrile neutropenia or something like that. You started on Miro and vancomycin or something, and then 48 hours later, patient is better, but cultures are negative. Easy to knock off the vancomycin because MRSA usually grows very rapidly, okay, in the blood culture. So if you've done a proper blood culture, unlikely that you will miss MRSA. The second patient that I showed, no, the child who had a metapneumovirus, had a ESBL Klebsiella by some in the culture, in the respiratory culture, but got meropenem, vancomycin, everything for 7 days or 10 days or something like that. So that is absence of de-escalation. So you had a culture positivity. See, first of all, I don't think they should have treated that Klebsiella at all because it is a community-acquired respiratory infection, metapneumovirus. So if at all you want to cover, you will cover pneumococcus or something like that. Maybe ceftriaxone or amoxiclav. There is no need to chase a Klebsiella in a ET culture. But anyway, even if you had, in that case, I think they should have just given something piptas or something rather than giving meropenem, vancomycin, azithromycin, oseltamivir, everything. So that is all absence of de-escalation. Okay. So, so going back to this one more step. So if you have started, say, MDR, a gram-negative cover, okay, you were not sure, so you started, but still 24 to 48 hours later, there is no bug growing, patient is absolutely fine. So probably we might have to start thinking whether we want to come off the MDR gram-negative, probably stick to something like a BLBLI or a carbapenem. So these all, see, these are not short things, okay? So there will be times when you will make mistakes. There will be times when you will have to go and revise, okay? But remember that the patient is in the ICU under your nose. So it's very easy for you to pick up if something happens and go back. You should have that courage to stop and see. That's all. If you have a culture, every time easy. All of us will do it. All of us will, I mean, should do it. Sometimes even with cultures, we don't de-escalate. That's the problem. But in the absence of cultures also, we should try to come off the the extra resistance, the resistant organisms that we're trying to cover, those covers we should try to come off and stick to a basic minimum. That's what I'm trying to say. Yeah. Anything else?
Not any questions. Next. And we've gone on for about 20 minutes. There are no further questions. I'd like to thank Dr. Vidya for this excellent presentation.
Yeah.
And we will have the next class in a week's time.
Yeah.
We will probably look at the topics later.
Yeah, so I think most likely we'll be doing gram positives and yeast in one class. We'll see how it goes. Okay.
Thank you.
Yeah.
Thank you,
Yeah.
in the
Yeah. Thank you all. Good night. I think I missed one question. Sorry, but even that we can do in the next class. I'll remember to continue. The gram positive talk. Dr. Anil Kumar, I'll do it in the next class.